Irene Bargellini from the University of Pisa, and she's going to be speaking about predicting outcomes in critical limb ischemia revascularization.
Thank you, Laura, and thanks for this opportunity of being here. It's an honor for me. And this is actually a presentation that comes from the discussion together with our diabetologist, Dr. Piagessi, who's the head of our diabetic foot clinic. And the reason why is that when I thought about outcomes of CLI revascularization, well, my idea is that technical issues come into play only partly, and there are many other several issues that has to be discussed. We know that a good revascularization will work much better than a bad one, and this is quite obvious. And we also know that operators' experience and the use of proper devices are extremely important to achieve a good recanalization procedure. We have learned that when we move down from the iliac vessels all the way to the foot, our chances for success will be lowered progressively. But at the same time, we have learned lately that we need to reach the foot arteries in order to achieve an adequate healing, particularly in the diabetic population. Also, lately, we have addressed the problem of direct revascularization, and we have learned that the efficacy of revascularization will be much higher if we target directly the wound-related arteries. However, all these technical issues will be discussed much more in depth by the next speakers. What I would like to point out, that these are data that come from the US Medicare population, is that patients that undergo tibial peroneal intervention are actually at high risk of periprocedural complications, and particularly at risk of amputation. And the risk of amputation is higher in those patients with gangrene, for instance, with congestive heart failure, and with diabetes. So there are several clinical factors that come into play when it comes to predict the outcomes of CLI revascularization. And for that reason, several scores have been developed over the years, such as the FINVAS score, the PREVENT-3 score, and lately the Krebs score for bypass grafts. And if you take a look at those parameters that are included in this scoring system, well, you see that some of them are actually repeated, such as coronary artery disease, foot gangrene, tissue loss or ulceration, emergent operation, age, for instance, dialysis. These are all poor predictors of prognosis, particularly gangrene, dialysis, heart disease. They are poor predictors of the outcome of CLI revascularization. And by the way, they are all found in a specific population of patients with PAD, particularly in diabetic patients. Because a foot like this